Hello and welcome. We're going to go on the record today with Dr. Morgan O'Donohue of O'Donohue Dermatology, and the subject's going to be skin cancer, a very serious topic, especially here in Florida, but also worldwide. So, Dr. O'Donohue, I'd like to welcome you and ask you right off the top. You chose dermatology as your specialty. What was the reason for that?
Well, you know, Bob, that's a great question, and I appreciate you having me in today. Dermatology is a fascinating specialty. And the fact that it's just such a visual specialty makes it unique. And I think what's important for both the doctor and the patient is that skin cancer is there for us to see. Unlike, let's say, a skin cancer, a cancer within the body, which may be detected by other means, a patient can do a self-exam and find this skin cancer early and therefore cure it early.
But how do they know what they're looking for? How do they know if they found something on their skin? Do they think, well, this is just a mosquito bite or this is something more serious?
Well, and that's the important key here, and the key is to educate. And I try and educate my patients every day in the office. And if we break it down into the three different types of skin cancers, these three types of skin cancers make up 99.9% of all cancers we see in the skin. The first type, and the most common type that makes up over 80% of the cancers on the skin we find, is basal cell carcinoma. And this is a cancer that will affect almost 1 in 5 Americans. And it typically will show up in sun-exposed areas, the head and neck, the arms, the hands, and it'll present usually as either a pink pearly bump, almost like a pimple, but a pimple that won't heal or go away. It can also present as a sore that won't heal, or even just sometimes as a flat pink patch of skin that just slowly is enlarging. The second most common type of skin cancer is squamous cell carcinoma. And squamous cell carcinoma approximately accounts for 20% of all the skin cancers that we see. It differs from basal cell in that basal cell doesn't tend to spread to other places. It tends to grow almost like an ulcer downwards into the skin.
Oh, down, okay.
Yeah, and where almost like a weed in your garden. Whereas squamous cells sometimes can actually metastasize. It can leave the confines of the skin and move on to either the lymph nodes or other parts of your body. So it's a little more aggressive. This will typically also present in areas of sun damage, sun-exposed areas, but it'll present more like maybe a wart or a scaly growth that just slowly presents or erupts. They usually, a squamous cell also will evolve out of something called an actinic keratosis, which is a precancerous lesion. And that's a little scaly, rough spot that about 20% of the time can evolve into a squamous cell carcinoma.
Now, these first two types that you just described, you mentioned sun-exposed areas primarily, but not exclusively, correct?
Not exclusively, no. In fact, you know, we know a lot about skin cancer, but we don't know everything. And that's why when I find a skin cancer on someone's scalp, or on their rear end, or on the bottom of their foot, I say to myself, there must be other factors here. And so heredity plays a role, maybe exposure to some external insult. Maybe as when they were growing up, some chemicals or some radiation. So that's why when I have patients in the office, I look them over from head to toe. I do a thorough exam, starting from the top and working my way down to the bottom and looking at everything. Right. Because skin cancer will show up in some unusual areas.
Now, you said there are three types. What's the third?
The third, and probably the most important, I would say, is melanoma. And melanoma, the reason it's so important is that although it only accounts for about 5% of skin cancers, it is responsible for over 80% of the deaths from skin cancer. So it can be a very aggressive and lethal tumor. The lesion can start from an existing mole that changes, or it can evolve de novo, meaning on its own, and it can usually present in a sun-exposed area as well as a pigmented lesion, meaning that it usually has either dark black or dark brown. We talk about the ABCDs of melanoma, and what that is A is asymmetry. So a melanoma usually will not be perfectly round. If you were to cut it right in half, one side may be will not match the other side. So very unusual to have it perfectly round. B in the ABCDs is border. Its border is usually very irregular. It may even look like it's sort of bleeding in, like an ink spot would on a piece of paper, you know, bleeding into the skin. C is its color, which I touched on, where you'll have a variation of sometimes black, brown, white, red. It's just not going to have a uniformity in its color. And then D would be diameter. And most melanomas, most pigmented lesions that turn into melanoma, typically are bigger than a pencil eraser, which is about 6 millimeters. You know, if you see a melanoma under 6 millimeters, it's usually a very, very early one. And melanoma has this propensity to leave the skin and move on to other places, like the lymph nodes, and then once it leaves the lymph nodes, it can go to any solid organ, the brain, the liver, the lung. And the key here is, and what I stress to my patients is that if we find it early, it can be completely cured with a little minor surgery. I mean, you know, a in-office procedure that takes about 30 minutes, we can cure their melanoma. If we find it late, sometimes it's too late. So, you know, when we think about other things in terms of the types of melanoma or the treatment, we have the earliest type, which is only 1/16 of an inch deep. Very, very thin. That's the type that it's stage 1, where I can excise it in the office and we've cured it.
That's when you want to find it.
That's exactly right. And stage 2 would be one then that has gone into the deeper layer of the skin, the dermis, and that is still confined to the skin, and still surgery can cure, but those patients I'll refer to an oncologist just for safe keeping and checking, and they may opt to do a CT scan, or they may even want to just check the lymph nodes just to see if any cells have gone there yet. Stage 3 and 4 are when it's left the skin, and it's either in the lymph nodes or it's in another part of the body. And in that situation, the prognosis is very poor, and sometimes the only thing we have to treat folks, particularly in stage 4, are palliative treatments like interferon or radiation, just to shrink the tumor size.
Wow, that's amazing.